Wow. It's really kind of hard to get back into the swing after a song like that. Very, very powerful. I think I have one that's more powerful at the end, however. By this stage, you may be wondering who this, as somebody described it, beautiful, sweet young lady is. Her name is Rosa, and she's one of my students, and she's in the Caribbean. And I'm going to tell you a story about Rosa at the very end when I play our biggest, most beautiful song. That's going to blow you away. And until then, I want to tell you one more thing. We're finished with chapter 11. We're done. We're done with that stinking old lecture part, and now we're going to have fun, and we're going to go to lab. We took a survey last year, and we asked the students, what do you enjoy more, lecture or lab? And they all say, lab, 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 lab. And I said, well, what do you think is more important for passing your boards? And they go, yeah, lecture. So this is the part of the time that I have the most fun with. Part of it is because I'm in my element or my habitat of looking through the microscope and showing people, which I did my whole life, even before I went into teaching. And it's really, really fun. This is our microscopy session. And remember, for those of you who enjoy or perhaps don't have the time for the lab, all of the lab sessions on all 500 of the cases, they're on YouTube. They're also can be downloaded in their original high-resolution form from medicalschoolpathology.com. And they're also on GoPath as well as streaming. So these are things that are all for your convenience, because when we teach medical school here, we're not teaching at our convenience, we're teaching at your convenience. And that's why we know that over 90% of you will be watching the movies rather than coming to the live session, but I certainly appreciate the live session too. I want to deal with one question that was asked again during the first hour, because I was thinking about it more, and I want to just try to bring this into our general principles of pathology and tumors. Remember, we have said many times from day one that the more undifferentiated or the more malignant a tumor is, the less likely it's going to look like the cells of origin. That's probably the main principle of tumor pathology. It's called the concept of differentiation. Now, somebody asked, could undifferentiated tumors also stain positive for the antigens? Like in this case, it was the factor VIII antigen we're talking about. And I said yes. And that's probably a correct answer. But remember, even way after your human eyeballs cannot recognize cells as coming from certain tissues of origin, the antigens within the cytoplasm or within the nucleus will still be there. And that's the beautiful about immunohistochemistry. I don't do much of it here because it's usually not a topic for students, but if you were to teach residents, everything now is IHC, or what we used to call immunoperoxidase or immunochemistry. Now they use the nice three-letter acronym IHC for immunohistochemistry for differentiating certain kinds of tumors. Let's go to lab. And if you remember, what we do in lab is we get up off our chairs here in the lecture hall and we take a nice walk down the hallway. Hey, don't forget your coat. And then we open up the door to the lab and we throw our coats on the lab chairs, and then we get out our keys or our combinations. We go to our lockers. We see if our microscopes are still there, if somebody stole them. We see if our glass slides are still there or if they're broke. You plug in the microscope. You take 20 minutes to try to tune it up. And then you say, oops, the light bulb is burned out. So you go into the store and you buy a light bulb. And you come back and then you focus it, and then you look at slides and you say, what the hell is this? So then you say, well, maybe our lab instructor knows the answer. So after 20 minutes, you're allowed to talk to the lab instructor because he's done talking to all the cute girls. And you say, what is this? And then he takes 20 minutes to focus his eyeballs, because his eyeballs are different from yours. And he looks at it and he goes, I don't know. So at least we have the advantage of all looking at everything together with somebody, me, who's seen these things a lot of times, and I generally know what I'm talking about. And sometimes, even when I don't, I'll pretend like I do, but I try to keep that to a minimum. So let's go to our first case. We have 12 cases today. Very often we have to jettison cases because we're running out of time, but I think we'll have time to talk about all 12 of these cases today. They relate very, very, very much to the topics we just talked about. Some of them we've actually seen before because on some of these things I've captured off of the microscope and putting onto the PowerPoint. So a good place to start, and once again, it's alphabetical. If you go to Rock Lab, you see the vascular stuff is alphabetical. So A is at the top of the list. And I guess the word adrenal begins with A. So we go to our slide in our slide box, K202, which is over here. You can see the thumbnail. And that's our first case. You already know where it is because it's alphabetical, so you know that's an adrenal. And let's put it under the microscope. And I know exactly when it's going to be in focus for your eyeballs. It's going to be in focus for your eyeballs right now. And sure enough, it looks like an adrenal gland. You can see some fat in the capsule. You could see the capsule surrounding the various layers of the adrenal. And if you could see, even from this low power, the most superficial layers of the adrenal look like little glomeruli, don't they? So that would be the zona glomerulosa. Yeah, they look like little glomeruli. And then as you go deeper down, they go into straight lines like fascicles. So that's the zona fasciculata. So I went to the G for glomerulosa, to the F for fasciculata. And now we'll drag down to another area here that isn't really straight lines, but it's more like a reticulated pattern. So you call that reticularis. And so you went from G to F to R. And isn't that funny because it's sitting right on top of the kidney where you have glomerular filtration rate. So these are the three layers of the adrenal. The glomerulosa has the mineral corticoids, the long fascicles, which is usually the majority of the thickness of the cortex, which is usually about 1 millimeter in real life, is a fasciculata, and that's this cortisol or the glucocorticoids. And then the reticularis is the reticular part that has the sex hormones, the androgen-like compounds. So you went from GFR, you went from salt to sugar to sex. And you know, one of the students actually made a comment on one of my YouTube things, and he goes, well, you know, that sounds like the deeper you go, the sweeter it gets. Okay, well, let's take a look at this adrenal. You know, these are some kind of artifact because they're not staining right, and I don't know, maybe this is something that was actually burned out once with a very high intensity light, but the adrenal doesn't look too bad. So you say, okay, well, Dr. Minarcik screwed up. He showed us a normal adrenal. And my only defense is that you have to look at everything, and sometimes you have to be boring, and you have to look around. And you know, when you get to this part of the adrenal, where you have large, wide open vascular spaces surrounded by smooth muscle, and sometimes maybe ganglion-looking cells, you know that that's the adrenal medulla. So you say, well, thank you very much for the nice normal histology thing, but what the hell are we doing here? Take a look at some of these blood vessels, like here, and here, and here, that are in the periadrenal fatty pericapsular connective tissue, and here. So this looks like a nice big one. Let's take a look at it. So I'm going to zoom in on the northeast over here by drawing my little box. And I'm going to start to ask you some questions. And the first question is, what the hell is this? Well, you know that's the easy part. You know it's a blood vessel. You could see it also has kind of a thick wall. So it's an artery, which somebody pointed out. But what do you see surrounding the artery and even towards the intima in many respects. You see inflammatory cells. Yeah, it's an artery, all right. Look, you could probably even see some fragments of adrenal tissue here, like there, way in the extreme northwest. But you could see a arterial wall that looks a lot redder and even more granular than the normal smooth muscle. So would you like to call that fibrinoid necrosis? Absolutely. This is a really good example. You have a blood vessel, an artery, a relatively small artery, that has inflammatory cells chiefly on the outside of the vessel, so peri-arterial. But you can also see that these inflammatory cells also involve the media, and they also involve the intima. So this is a pan-arteritis, right? All three layers. But it's also a periarteritis because most of the inflammation is on the adventitial and outer muscular layers. So would somebody like to venture diagnosis? We said it's a periarteritis. What if I was to tell you that grossly this artery might have a nodular appearance? Because the artery is being affected only in little segmental fashions. We have a periarteritis, and it's nodular. And of course, I already gave you the diagnosis. It's periarteritis nodosa. If you wanted to call this polyarteritis nodosa, because we saw that other arteries are involved as well, would it be the same term? And of course, the answer is yes. Okay, so what else do I want to say about this? Oh yeah, here's what I wanted to say. This is a classical example of a systemic autoimmune disease, polyarteritis nodosa. We talked about it when we were talking about the immune diseases. And isn't it kind of unusual is that when we told you that there's basically two types of arterial diseases, there's atherosclerosis, number one, and number two, everything else. Isn't it kind of unusual that with atherosclerosis, the primary process is intimal and subintimal and towards the lumen of the vessel, but with the arteritides, the primary destructive process is peri, or around the artery. And yeah, I agree that there's some stuff here on the intima as well. So could you keep that as a general thing in mind, is that atherosclerosis starts out in the intima, and quite frankly in the endothelium originally, but the arteritides very often are surrounding the artery. The worst part of it is around the artery. So this is polyarteritis nodosa. Okay, now this is the number one question. Let's say that I told you that this patient also happens to have a diagnosis of either lupus or rheumatoid arthritis. Would you then want to say that maybe this vasculitis is part of the lupus, or the vasculitis is part of the rheumatoid arthritis, rather than go and diagnose a whole different new autoimmune disease? And of course, everybody is saying yes, 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 yes. So, good, you got everything right so far. Now, here's the real trick question now. Is there anything about the pattern of inflammation in this artery that would differentiate it between an arteritis secondary to rheumatoid arthritis or a polyarteritis nodosa? In other words, if I showed this to, the last 10 pathologists that won Nobel Prizes, and I said, okay, is this part of rheumatoid or is this periarteritis nodosa? Tell us if you could tell the difference. And in all honesty, they'd have to say no. So yes, you got that question correct too. And we could look at another couple of arteries pretty briefly as well if you want to. We saw the one up here in the northwest, but here, let's take a look at the one down here in Texas. And I think you can see they all look about the same. It's basically a polyarteritis, but there is some trans or pan arterial wall involvement too. So there's another one. And you want to see another one? Oh, let's take some of these smaller ones out here. They all look pretty much the same. And remember, we're dealing with more than one artery here, aren't we? So by definition, that makes it polyarteritis. Now, could there also be arteries supplying the brain or small bowel or liver that are also inflamed with this disease? If it's polyarteritis? And of course the answer is yes. You got that one right too. Now, I want to show you something really cool, because I've been talking about fibrinoid necrosis, and you've probably been saying, oh, Minarcik doesn't know what he's talking about. He talks about fibrinoid necrosis, amyloid, hyaline. Gee, it all looks like red junky stuff to me. How does he know? Well, here, take a look at this relatively normal small artery here. Do you see how it has a sort of a uniform, pink, smooth display of smooth muscle cytoplasm? Now, take a look at this artery here. Do you see how it's more red and more granular and less smooth? That is fibrinoid necrosis. So a good question would be, what is the usual pattern of necrosis in arteritis? The answer is fibrinoid necrosis. What if I said, what is the usual pattern of necrosis in brain injury? Well, you'd probably say liquefactive necrosis. What if I said, what's the usual pattern of necrosis in large TB granulomas? You'd probably say caseous necrosis. These are just conventional terms, and they're not meant to, exclude anything. So you all got the questions right. So that means we can move on to the next case. And the next case will be, it's called AUT03. So I guess we have to go to the A's. And looks like the A's are over here. AUT03. Here it is. See, there's the thumbnail, folks. Anybody want to guess what that is already? Just from looking at the thumbnail? I'll give you an A for the class if you get it. And you can say it looks like the arches at McDonald's. Well, maybe you get a B. Yeah, you could tell it's an artery. I'll give you half credit for that. Now, can I ask another question? Because as of right now, you're all looking at it. And yeah, I agree. It looks like a blood vessel wall. And can I ask, what kind of blood vessel you think this is? You think this is an arterial, a muscular artery, or a really, really big artery? Is it an aorta? Anybody want to take a guess? No, nobody wants to take a guess. Well, it's awfully thick, that's for sure. And somebody said elastic. Well, that's really a very astute observation, because I'm going to blow up the middle of this wall. And remember, this whole thing is nothing but blood vessel wall. Now, here's the question. Do you see these little white squiggly fibers? I know they look white. Like here, this is a good one right here. You see this whitish squiggly line? You see this whitish squiggly line? You see this whitish squiggly line, and this one, and this one, and this one, and this one, all the way through. What are these white squiggly lines? Remember, this is just the H&E stain. These are elastic fibers, absolutely. And what if I told you that if you did an elastin stain, this perfectly white, pinkish, squiggly line would now be intensely black? Then it would prove it was an elastic fiber. But don't think that you can only see elastic fibers with an elastic stain. When you look at a normal aorta with just regular H&E, you can see they're all over the place. Okay, so now we know that there's a lot of elastic in the aorta. Well, big deal. Everybody knew that anyway. What if it was what we call an elastic artery, like an innominate, or the origin of a carotid or something like that? Would you expect to see elastin fibers all the way throughout the artery, or perhaps just towards the middle portions? They certainly have more than just the internal elastic lamina. They'd have a lot of elastic fibers. Maybe not as much as in the aorta, however. So we're back down to our regular pictures. Now, here's the next question. We said that every artery has 3 layers: intima, media, and adventitia. Well, when you see all this connective tissue and blood vessels and fat, you know this is adventitia. So it means this is the media, right? And now the other side has to be the intima. So if we're calling this part here the intima, then we have to prove it by zooming in and maybe finding a few endothelial cells. Look, there's an endothelial cell. Some of these could be too, but when you see a nice little flat cell like that right on the surface, you know that's an endothelial cell. Now, can I ask another question? What is this white, pink, squiggly line here, and here, and here, and here? These are all elastic fibers again. No, somebody said vasa vasorum. Remember, vasa vasorum, if you see a blood vessel within a blood vessel, by definition, that's a vasa vasorum. But as you know, most of the vasa vasorums will be towards the adventitial aspect. Because the reason why you need the outside of the artery with blood vessels is because it's not right up against the blood. So the further you are towards the outside of an artery, and here certainly in the adventitia you have a lot of vasa vasorum, and sometimes they protrude down here, like here, into the media as well. But as you go towards the middle of the media and then towards the intima, they almost disappear because you don't need blood vessels all the way down here. You got blood right up here against your intima. So let's just kind of move along the intima. And are you thinking, well, maybe this intima looks just a little bit whiter and foamier than normal? Like, and you're thinking, could some of these things maybe be foamy macrophages? I don't know. That's your thing that you're wondering about. But let's go back to the big picture now and look at the other side of the aorta. Well, once again, here's adventitia, here's media, but look, now you have sort of like a little whitish, foamy substance on the intima. And I'm going to blow it up for you up here in Minnesota. And I want to ask you, what's all this white stuff? Yeah, it's a plaque. Ah ha ha ha. Somebody said plaque. And that's up for discussion now, because it's only a plaque if you could put on a blindfold and feel it. If the only evidence you had for it is that it looked yellow, would you call it a plaque or would you call it a fatty streak? Well, the reason why I'm asking you that is because this particular slide was labeled as fatty streak. However, in all honesty, if you really think that you could feel this little bump and it is not just yellow, but you could feel it, then it would deserve to be called a plaque rather than a streak. Otherwise, if it's just very, very subtle, you know, like this, and maybe you see some foamy cells, like here, for example, you might tend to call it a plaque. But if you can really feel it, if your fingers are gooder than mine, and you could call it a plaque. Otherwise, this was labeled as fatty streak. But that's debatable, isn't it? Now, let's zoom into this area here, the part that we're talking about. And I want to ask you one last question. What are 90% of these cells that you see here? Fat is correct. Anybody want to be more specific? Foam cells. Anybody want to be even more specific than that? How about foamy macrophages? Okay, so you know that the foam inside these macrophages are cholesterol and cholesterol esters. Now, let me ask you this. If this foam wasn't just intracytoplasmic, but it was big enough to cause actual crystals outside the cells, what would you call those little spaces then, those little needle-shaped spaces? You call them cholesterol clefts, wouldn't you? except you don't really see any good cholesterol clefts here. It's mostly foam cells. So what comes first, the foam cell or the cholesterol cleft? And of course the foam cell comes first. Okay, good. I'm glad this was not a chicken versus egg question, because I never get that one right. Let's go on to the next case. And this is going to be number 039. So here's O and here's 39. And take a look at it. It looks like another aorta, doesn't it? And it looks like a double aorta again. And you can already tell that probably on this side of the aorta, it looks like it's maybe fat. So that's probably going to be the adventitia. And it looks like there's some adventitia here. But look, looks like there's also some thickening on the other side, which means you know what this is also going to show. Bingo. This is connective tissue. There's even some nerves. Remember, the aorta has nerves on it, the sympathetic, chiefly sympathetic fibers. Here's some fat, here's some veins, here's some fibroblasts, and here. So this is the endothelial end of the artery, which is the intima, and here's the adventitia, and the dense pink stuff is basically the media. Now, can I ask another question? How do you know this is an aorta? Again, here I'll help answer that question by giving you a full thickness slice. So the question is, how do you know this is an aorta? Well, it's because, once again, these really subtle pink squiggly things extend the whole length of the media. The aorta is the only elastic artery in which these elastic fibers go all the way from the intima to the adventitia. And if you don't believe these are elastic fibers, then you do the elastic stain. Okay, so if we said that this was the intimal end and this was the adventitial end, can I ask you one thing? What are these little slit-like spaces over here? Here and here and here and all over the place. Yeah, these are the cholesterol clefts. And the reason why you just have to call them clefts is, cholesterol is a fat, and like every other fat in the body, it looks yellow grossly, but it also gets dissolved when the tissue is processed. So if we didn't have xylene in the preparation here, you'd maybe actually see the actual crystals. But the problem is it might cut in a very jagged way. So that's why we have to make sure all the crystalline, hard, gritty material is out before it can make nice thin sections. So this may be kind of boring, but, all you see here is fibrous tissue, cholesterol clefts, maybe some foam cells. You may and probably won't see a good dividing line between the intima and the media because, it's not fine. Fibroblasts have migrated. It's very disrupted. And this is probably about as good as a separation as you'll ever see. And whereas most of the things you're seeing here are clefts, I bet you if we go a little bit deeper, you can see some residual foam cells too. And if I'm wrong, I'm wrong. But I think that these are probably foam cells. Aha! We just got another substance here, which we were not expecting to find. What is this very, very, very dark blue, gritty stuff? And yeah, you already know that. That's calcium. So the cholesterol clefts are crystals, but they dissolve out, but the calcium doesn't. In fact, if this was really calcified, chances are when you cut through it at autopsy, you would hear it. It would be crunchy, just like when you do a angioplasty. You hear the crunchiness of the calcium breaking up. Otherwise, probably most of these cells are fibroblasts. And, I wouldn't be surprised if this could be a foamy macrophage here and maybe one here. Maybe a couple over here. So this is another more advanced lesion than we saw before because the predominant calcium here now is in cholesterol clefts. It's not in foamy macrophages. And cholesterol clefts are more likely to be in plaques than in streaks because as you progress from a fatty streak to a plaque, you generally get more cholesterol, so you go from just the foamy macrophages. Somebody said, could this be a vasa vasorum? Okay, well, what is a vasa vasorum? A vasa vasorum is a blood vessel within a blood vessel. But remember one thing. The atherosclerotic process is an inflammatory process. And normally you have blood vessels growing within this inflammatory process. I would not call this a vasa vasorum. If there were blood vessels in here, and there may very well be, you would call those blood vessels as part of the reaction of inflammatory plaque. Technically speaking, vasa vasorum are blood vessels which grow mostly towards the other end of the artery, and they supply and feed the outer portions of the media and extensively throughout the adventitia as well. So here, I'm going to show you some nice vasa vasorum if I can. Oh, there's one. There's one. That's definitely one. That's definitely one. And as you go more towards the media, they get a little bit more rare. And sometimes you could see them actually in here. And of course, the adventitia is very, very rich in blood vessels. There's a major, major vein alongside that aorta over there. And I bet you there's another vein. And looks like that's an artery. Oh, that's definitely an artery because look at the thickness of the muscle. And sometimes when you see like a couple arteries together, don't think they're different arteries. It's probably the same artery that's been cut in different planes. And last but not least, I wouldn't be fair to you if I didn't find a nice nerve. So please stop me when you see the nerve. Bingo. That should be a complete instant knee-jerk reflex of a nerve. Okay? And it's myelinated because most of the nuclei you see there are Schwann cells. Now let me ask you this. Is this most likely to be a sympathetic nerve? Yes. Okay, correct answer. Let's go down to the next case now. You're doing so good today. This will be 4790 is the next one. If it seems like we're spending a lot of time on atherosclerosis, I want to remind you that's going to be the disease that you spend most of your time treating. So 4790 looks like it has to be somewhere around here. 4790. Here you go. It doesn't have a thumbnail for some reason, but I know it works because I tested it twice yesterday. And you see it right now. And it's a good thing there wasn't a thumbnail because I think that this pretty much gives it away. So let me ask you two questions about this one slide here. Question number one, what's the disease? Just answer it right away. Question number two, what is superimposed onto this disease? Thrombosis and atherosclerosis. Absolutely right. That's so important to remember because heart attacks don't occur from atherosclerosis, or any acute coronary syndrome does not occur just through atherosclerosis. It's atherosclerosis plus there's been enough intimal damage to evoke a thrombosis as well. So the majority of this compromise of this lumen is actually with a thrombus rather than atherosclerosis. Now, I must admit that when you get to an area like this, it's hard to say where the atherosclerosis ends and where the thrombosis begins. So most of this really red stuff here is blood clot rather than atherosclerotic plaque. Okay, second question is this. What percent of the normal diameter of this blood vessel is occluded or compromised by this double disease process? And I'm seeing all the answers in the high, I'm seeing 90, 95, 90, greater than 90. And that's what I would say too. Not 100, but probably at least 90, I would think. And okay, pretty good. Here's some fat within a plaque. Most of the thickness of this thing is plaque, so this lighter area is probably, we'll see foamy cells. I think from even this power, you can see some cholesterol clefts. Maybe we'll see some calcium microscopically. In fact, hell, let's take a look right now. Yeah, here's cholesterol clefts. Here's foamy stuff. Here's more clefts. Here's part of the thrombus. I don't really see any calcium here, but I bet you if I scouted around a little bit faster than you could catch up with me, we'd probably find a little bit of calcium here and there. But up until now, I don't see any calcium. Okay, now let me ask you a key question here. What do you think all of these, or most of these, white spaces are within this thrombus? Somebody said fat, somebody said necrosis, somebody said blood vessels. Here, let's make this easy. You see this white space here? I'm going to blow it up really big. There you go. There's a white space. There's a white space. This white space happens to be lined by flat cells. So what kind of structure is this? This is a blood vessel. Okay, so you have blood vessel inside of a severely damaged artery. It could be due to 3 reasons. Number 1, it could be normal vasa vasorum, which you don't usually see in the intima. Anyway, number 2, it could be organizing or neovascular changes within this thrombosis. Or number 3, it could be recanalization. That would be a great board question. In fact, I'm asking it right now. Aha, somebody got the right answer. It's organization. Well, it wouldn't be a vasa vasorum because it's not towards the outside of the vessel. And there's so many other vessels in here, I would not call this recanalization. However, let's go to that little slit-like space. And we're going to do that right now. And the little slit-like space was over here. That was what we called the remnant, or the 10% remnant. And let's blow it up a little bit. This is probably the remnant of the lumen. Well, on this side, it looks like it's just part of the thrombus, but it's no more likely if you were to look throughout here, you might see endothelial cells, because that's all that's left for the blood to flow through. What if there was another sizable endothelial line space somewhere at the edge of this thrombus? What would you probably call that? Yes, that would be called recanalization. Now, I would not call this recanalization because it looks like it's just the remnant of the lumen. And certainly all these blood vessels here, you would not call recanalization. They're just organizing changes within the thrombus. So, here's the question. Is this thrombus recent, like within 24 hours? Or is it old, like maybe months old? Or is it in that intermediate stage that we call organizing? Yeah, it's organizing, isn't it? If it was recent, it would be almost all fibrin, wouldn't it? If it was remote or old, it would be almost all fibrous tissue. But when you see blood vessels, it's in that intermediate stage called organizing. Now, as this thrombus ages, you get more fibroblasts and less blood vessels. And that means you're going from the time period of approximately days to either weeks or months or years. So this is a pretty severely involved artery, isn't it? Okay, last question. We're going to do something very clinical right now because, you know, I know you've been primed to learn that pathology should be clinical, clinical, clinical. That means that most of the people that teach pathology in the world don't know a damn thing about pathology because they're not pathologists. But I want to ask you a final question. Do you think that if this artery happened to be the left anterior descending or the circumflex, do you think that patient would be symptomatic right now? maybe with the infarct, maybe with chest pain. Okay, good. Now, here's the final question. If this artery was the left main coronary artery, do you think this patient would be alive right now? Thank you. You got this correct answer. Okay, in fact, we are already leading into the topic on heart now, aren't we? Okay, let's do another case. We did very well on this one. Let's have some more fun now and go to 3627. And this is going to be a great case. And I bet you none of you will get it. But we'll see. Maybe there'll be some wise guys out there. 3627 looks like it's over here. There you go. See that? It's highlighted. Anybody want to give me a diagnosis off of the thumbnail yet? Of course not. Not unless you cheated and looked at this in lab. Fat tissue. That's about as good as it can get. And yes, there is fat. There's fat here, there's fat here, there's fat here. There's a lot of fat. But we're talking about the stuff here in the middle of the fat. For example, do you think these three things out here are arteries? Yeah, they are. And they look like they're sort of normal arteries. They certainly have thick walls, and they certainly have wide open lumens, and it doesn't look like they have any plaque. In fact, could this most likely be the same artery that's just cut three different ways? Or do you think this is three completely separate arteries? There's probably the same artery. You remember in histology, the tissue squiggles, it's in 3 dimensions. But what about this artery here? And what about this artery here? And what about this artery here? And what about this artery here? So here's the first easy question. Let's take the artery up here in the northeast. What percentage of its lumen is occluded, or obliterated, or stenosed, or compromised? And I'm seeing high numbers, anywhere from 40 to about 70, and that's probably what I would say too. Now, what about this artery here in the southeast? What percentage of its lumen is obliterated? Oh, I'm seeing anywhere from 99s to 100s over here. I would say it's virtually completely obliterated. What about this one over here? What percentage are you going to give me over here? 95 or something? Who knows? Yeah, sounds good. How about 96.37214? Would you agree with that? Let's open up and explode one of these big arteries now, like this one here, the big one that looks like it's obliterated. And let me ask you a question. Do you think this is atherosclerosis? Look at that beautiful internal elastic lamina, that squiggly little mountainous highway that goes all the way around the lumen, which is virtually obliterated. And there's no plaque, there's no calcium, there's no foamy macrophages, there's no cholesterol clefts, there's no fibrosis. It looks like it's inflamed. It looks like it's organizing inflammatory tissue. So number one, it looks obliterated. And number two, because of it's inflamed, you might also use the word angiitis or vasculitis. And it looks like it's thrombosed, not by blood clot, not by plaque, but by this inflammatory process within the intima. So let's see, what do we have here? We have thrombosis, we have angiitis, we have obliteration. What if I was to invent a disease called obliterated thrombosis angiitis? Hey, there is a disease. It's called thromboangiitis obliterans. Do you remember what the other name for this disease is? We talked about it a little bit the other day. Yeah, it's Berger's disease. This is classical Berger's diseases. Now, the one thing I forgot to tell you about Berger's disease, and I remember now, is, I'm an old guy. I'm going to be 65 in a couple months. But if you were to ask me, what is the most memorable picture I ever saw in medical school? And it was a picture of a guy with thromboangiitis obliterans. He smoked. He smoked so bad that he lost his leg. And he kept on smoking. So guess what? He lost his other leg. He kept on smoking, so he lost his arm. he kept on smoking, so he lost his other arm. And the picture that I saw was basically a guy without arms or legs laying down in a hospital bed, and guess what he had in his mouth? It was the most unbelievable picture I've ever seen in my life. Yeah, he had a cigarette. And at least you could see that this is not really atherosclerosis. But another thing is, if I was to tell you that this is the most beautiful example of a perfectly intact internal elastic lamina, you don't even need an elastic stain for it, you would believe me. And that's basically what's going on here. Okay, so much for Berger's disease. Let's go to, by the way, the main treatment for Berger's disease is to quit smoking, as you might guess, but cigarette smoke damages blood vessels. That's a well-known fact. But in some people, their endotheliums are extremely sensitive to cigarette smoke, some genetic reason. And those are the people, that lose their arms and legs from smoking. Let's go to 4066. We're about halfway done. 4066. Here we go. See it? Here's the thumbnail. Somebody want to give me a diagnosis from the thumbnail? Somebody want to tell me what these big things are at the top of the thumbnail? Anybody want to take a wild stab at it? Take a shot at the title? Somebody said thrombi, and somebody said brain. And guess what? You're both right. Probably on very, very quick recognition, the tissue on the bottom, in the southern hemisphere here, looks like brain. We could do a quick reality check and say, yeah, there's a lot of oligodendrocytes, there's a lot of blood vessels. I don't see too many neurons, but it looks like classical brain. That thing you say is a knee-jerk reflex. Okay, so we know this is brain tissue. Big deal. Let's not go into it anymore. Now, it looks like compressing this big brain tissue are large spaces, look like with fairly thick walls, and there's a lot of blood clot or blood in these large spaces. So somebody's already given me the correct diagnosis. AVM, arteriovenous malformation. Do you notice how they can have kind of a mass effect? This is an AVM of the brain. What if somebody said to me, well, could this be a hemangioma of the brain rather than an AVM? And I would say, you know what? It's probably going to be very, very hard to differentiate that microscopically. But what if we were to zoom in on the blood vessels over here, the wall of the blood vessel, and you would say, well, this doesn't really look like an artery because it has such a wide open lumen. But nevertheless, the wall of it is very, very thick, probably about as thick as an inferior vena cava. So why would a vein-like structure decide to get a very, very thick wall? Because of increased pressure. And the increased pressure is coming from the fact that the arterial blood in this malformation is mixing in with the venous blood. So the venous blood winds up having a thick wall. And let's say that the wall thickness can't keep up with the increased pressure. What do you think is going to happen? There's going to be hemorrhage within that brain. So the two ways AVMs of the brain can kill you, and I've gotten about 8 emails from my movie on AVM from people, and they say, my son, my father, my sister died of this. And they died probably either because it was a large mass effect on a critically important part of the brain, or more likely the pressure of the venous part of the malformation couldn't keep up with the arterial and the wall ruptured and there's acute hemorrhage within the brain. So those are the two ways AVMs can kill you. So do we really want to say anything more about this? Yeah, let's take a quick picture again. And if you were to call this a hemangioma on a test, I wouldn't blame you. I might call it a hemangioma as well. But this one happened to be labeled AVM of the brain. Let's look at 4009 now, as long as we're doing such good progress here. 4009 looks like it's over here. There's the thumbnail, folks. Anybody want to guess at the diagnosis? Yeah, blood vessels. Do they look like they have all the uniform lumen or some? Yeah, okay, shit. I can't fool you. You all know this is atherosclerosis, but I'm going to show this slide anyway. It's certainly not an aorta. What if I were to tell you these were coronary artery sections? And look, in this one vessel, you have a relatively normal vessel on the southern side of the vessel, but on the northern side of the vessel, the wall was 3 or 4 times as thick as it should be, and it's all this foamy material. On this blood vessel, the eastern side looks pretty normal, but the western side has this big plaque. And do you see how this thing looks a little bit bluer than this? I bet you if we zoomed in on that, we'll find calcium there. And look, do you also see on this blood vessel, it's kind of normal on the bottom again, but the top part is about 8 times thicker than the normal part. This is all plaque again. And look at that red stuff is probably blood vessels. And I bet you those little slits are cholesterol clefts. So what do you want to go after now? Let's look at the normal part of the artery. That's a good place to start. These are coronary blood vessels. There you go. There's your intima. You probably can see internal elastic lamina. See that light squiggly thing? And then you see some nice smooth muscle layers. And then you see looser connective tissue. And then you kind of lead into this area here where you're getting to have a lot of thickening of the wall. And you're losing the integrity. You see, here's the internal elastic lamina. You're losing the integrity. You're seeing cholesterol crystals. You're seeing foam cells. And almost the entire thickness of this wall now is plaque. Look, this is all cholesterol crystals. And do you see where it's starting to get a little bit bluer? Do you think if we were to look for calcium, we'd look in this bluer area? Do you think that's the nucleus of a foam cell, or do you think that's a fleck of calcium? Well, to tell you the truth, I don't know myself. What about those little granules over there in the extreme northwest? What do you think that is? Those are little calcified microparticles, aren't they? These are all cholesterol crystals. And what we'll do now is we'll go to the one up here on the top that looks like it's quite a bit bluer than this foamier stuff. And I bet you, maybe I'm wrong because I didn't look at this part before. I'm betting you we'll see some calcium here too. Yeah, look at these are all calcium flecks. You see that? Here's cholesterol. Here's fibroblasts. Now, the one thing that is very often difficult to differentiate in a plaque is to whether some of these cells are migrated smooth muscle cells versus fibroblasts. But let's say, for example, we did a Masson trichrome stain, and most of this pink stuff here remained pink. Then you would probably guess that most of these are smooth muscle cells. But let's say that the part over here was green. Then you say probably most of these cells are fibroblasts. And don't feel bad, because I could tell you, even like my really, really good pathologist friends that are, crackerjack pathologists, even on a good day, sometimes they can't tell whether an individual cell is a fibroblast or a smooth muscle cell, so don't feel bad. So instead, let's move on to the next case. And we have only 5 more cases left, and I see we only have 5 more minutes left. So guess what? We're going to have to narrow this down. Okay, guess what? I decided we're going to take just one more case, and it's 3945. You see, we have so much fun doing this, I lose track of time, and that's why I always have to abandon some cases at the end. There's 3945 over there. I know you can all see it. What does it look like to you on the thumbnail? Yeah, it looks like a vessel. Would you say it's a vessel with a thick wall? Yeah. It's an irregularly thick wall? Yeah. So let's put it under the microscope. And I know you can all see it as of right now. So yeah, these are thick-walled blood vessels. But can I ask you a question? I'll blow it up even more. Are there inflammatory cells on the outside and in the middle, and a little bit less likely towards the intima? So it's an arteritis, isn't it? Aha. Now, you see this area here where there's a lot of inflammatory cells? Let's zoom in on that. And that's exactly what I'm going to do. So yeah, there's a lot of inflammatory cells there. You got the answer before I even showed it. That's not fair. I'm going to flunk you guys, whoever you are. I don't even know who you are because I don't look at the names. But look at, these are multi-nucleated giant cells in areas of fairly well-defined collections of inflammatory cells. These are giant cells, and it's an arteritis. So what do you think a good name for this would be? Giant cell arteritis. Haha, got the right answer. Which artery is giant cell arteritis most often diagnosed in? Temporal. Why is it mostly diagnosed in temporal? Because that's one artery that's not only very easy to biopsy, but it's an area that has an abundant amount of collateral circulation from other arteries as well. Even though giant cell arteritis may be involving intracranial arteries and ophthalmic arteries, and the patient is going blind, the only place you could see it, even grossly, is in the temporal artery. So there we go. Last question about this case is, if this patient with temporal or giant cell arteritis, now it's biopsy proven, if this patient also had an extremely high erythrocyte sedimentation rate, then what disease would you diagnose? It's not an easy question. It means you had to be listening careful the other day. Well, it's called polymyalgia rheumatica. So if you don't want to go to Google or Wiki and look at everything about the disease, just remember, polymyalgia rheumatica, also, like giant cell arteritis, an autoimmune disease, systemic autoimmune disease, has two things. Number one, it has giant cell arteritis, and number two, it has sky-high elevated erythrocyte sedimentation rates. We're done for the day. It's exactly 11 o'clock. I know you've been working hard, so I don't want to take you too much after the hour. And also, I feel like I got to reward myself by quitting also. But I will take a look at the question box, and see if anybody wants to raise their hand about anything. Because if I didn't give you the chance to speak, then you might as well just be watching the damn movies and not coming to the classes. So I'm going to look at our attendee list. I'm popping out the window. We still have a really large number of people still here. Nobody has their hands up, and that's okay. At least I gave you the chance. Now, we're going to quit. I want to tell you the story about this girl, Rosa. Rosa's father came over here from another country about 10 years ago, and he wanted to bring his family over. She was just a little girl then, okay? Well, it just so happens that when he came over, it happened to be on 9/11. So it took him 10 years or 8 years to get his family to be with him finally. And during those 8 years, Rosa Muradi's father waited patiently and loyally for his family. And when she told me that story, I practically fell over. And that's why I'm dedicating this class to her and her father with the most beautiful song I could think of right now by Juice Newton. See you in a couple of days, folks.